All right, hello. Thanks for joining the May 25th VTC Wellness Medicine Journal Club series. Tonight's focus is podiatry in the wild. We have 3 articles we're going to cover today and be separately presented by 3 different volunteers. This topic is probably not focused on unless you go to like the summer WMS conferences, but it is actually pretty important. If you've done any race support for ultramarathons, marathons, if you're on a backpacking trip, through hiking in bad environments, if you have poor foot care, poor fitting shoes, not knowledgeable about blister prevention and blister care, you're going to have a rough time, especially as an expedition doc or medic as well. So with that being said, I think that what would be a good intro would be the article by Grant Lippman. Just remind me out of the 3 presenters, because I'm in a bit of a fog state right now. Which of you selected the article by Grant Lippman?
That would be me. I got the Grant Lippman et al. The paper tape prevents foot blisters.
Perfect. So I've got it so all participants can share. So whenever you feel ready, go ahead if you want your screen to be shared. If you just want to turn your video on or however you want to present, feel free. I'm going to mute myself. Take it away.
All right, great. So just to introduce myself, my name is Alex Borzak. I am actually a nurse practitioner in Pennsylvania in Lancaster area. I dabbled in a little bit of emergency medicine. I'm going into a little bit of a transition myself. I'm going more into clinical education now, but I do practice as part of the medical team for a search and rescue group up here in southeastern Pennsylvania. The group that I work with, our territory is basically Lancaster County, Bucks County, Dauphin County, and Delaware County, and we go up into down into the Philadelphia suburbs and city and stuff like that as well. But we go all over Pennsylvania if we need to get called in and asked for by another team. So before I start in on the article, I just wanted to give a brief overview on kind of a little segue to get us into talking about paper tape. So the article that I'm going to review and talk a little bit about is the paper tape prevents foot blisters, randomized prevention trial assessing paper tape and endurance distances. But just wanted to talk really quickly about just basic causation of blisters, some basic different types of blisters, and just kind of what ways to prevent them. I'm sure we'll get more of that with the especially with the randomized controlled or not the control trial, excuse me, the systematic review that's going to be presented here. All the stuff that I pull out from is from Auerbach Wilderness Medicine 7th edition, volume 1. So if you have that on your bookshelf, you can easily refer to that. So this is where I scanned the pictures and stuff like that, just because I don't have, I didn't get to my catalog of gross blister pictures. So I just kind of brought those in. Anyway, so what causes blisters? Pretty much basically shear force coupled with friction. So just that, first of all, you have that rubbing from some sort of surface, whether it be a sock, whether it be actually the shoe or other material against the skin continuously in one area. But then you also have that pressing down motion, pushing along, adding in that direct downward angular pressure into the skin. So you're not just getting surface injury, but you're also getting more deep tissue injury. This is caused by loose fitting shoes, moist feet, footwear, socks, calluses. Even if you've gone to the length of filing down your calluses, if you haven't given them enough time to heal over, these can cause blisters. And we'll talk about foot preparation, but whether or not you prepare ahead of time in advance, or you just kind of throw some socks on, throw some shoes on, and decide to go run a 5K race or something like that the same day. You're hit with inspiration the night before. That also ties into causation if you aren't properly prepared or practiced as well. So this is just a diagram kind of demonstrating the force here. So you have the friction force that's kind of going parallel along the skin, and then the shear force that's pressing down with that kind of like angulated. They have the vector direction going down deep into the tissue there. Different types. So you have hotspot, no Wi-Fi involved. So this is the beginning area of blister. So area of redness, tenderness, erythema, where this excessive rubbing is irritating the skin. This is the pre-blister stage. So you have this irritation, and if you don't address it, then you develop into the actual blister. So typically they're delegated by anatomic location. So particularly on the foot, which is our kind of our focus here, at least with my article: toe, heel, dorsum, plantar aspect, ball of foot, subungual, and you have some different types. So subungual hematoma, which can be toenail, fingernail, blood collection there, blood-filled blisters, or even those subcallus blisters, which are underneath of a callus of the foot. And they all have their different ways to manage them once they do develop. Don't really get into that, but here's a couple examples of a couple different blisters. On the right-hand side of the screen is just a large open heel blister on the back of the heel. And then next to it is just a blood blister, just to kind of give you an example of a couple different types there. And then prevention, you want to decrease or eliminate the effective shear force coupled with friction. So this means well-fitting shoes. You don't want anything too tight or too loose. Dry feet, footwear, socks, calluses filed and given time to heal. Foot preparation, you want to make it a spa day. No calluses. There's a little bit, you read into Auerbach and stuff like that. There's discussion on whether, a soft, supple foot that is, you take months and you get it nice and moist and well, the tissue's well taken care of. Or if you want more of a drier foot, going into a race or expedition or something like that, there's some discussion in Auerbach on that. You can read that outside of this if you're interested. But then also repeated exposure to low intensity friction forces. So you're not necessarily building calluses necessarily, but you're building up more firmness within those top layers of tissue to desensitize that area. And then also pre-taping application. One caveat with this is you want to ensure even distribution, no crinkles. This also goes in with casting and stuff like that, with the web reel, layering and stuff like that. You want to make sure, again, you don't want to have any crinkles or those open spaces. Athletic training was a big thing. Part of my background is athletic training, doing any type of taping, particularly on the feet. You want to make sure that you don't have any open little spaces, because those are areas that are going to cause the friction and cause blisters and stuff. In the article, the authors talk about, and also in Auerbach, they talk about these Injinji socks, which runners wear. And basically what they are, they're a wool sock, but they have individual little toelets. They're really kind of interesting. They come in all different kind of colors and patterns and stuff like that. Very high fashion. But the point here is to separate the toes, make sure you reduce those areas for friction and stuff like that. And then the pre-tape, this is what the authors did in their study, is this type of pre-taping with paper tape. So there's an actual picture demonstration of what the article itself is going to be focused on. And then there's a bunch of different other products out there, down to duct tape, to moleskin, and different things. And I'm sure we'll get into that later with the systematic review. Again, reference Auerbach's Wilderness Medicine. So that's just a little pre-warm-up to get us into the topic, and also get us into the article actually that I'm going to be talking about, which is the study regarding the paper tape. So let me just pull that up here. Anyone, questions, comments, anything you guys want to add anything in before I jump into the paper at all?
No, great job with that intro. Keep it going unless anybody else has questions.
Okay, cool. All righty, so let's get into this then. So again, so this article deals with paper tape, and what they're doing is they're looking at probably the most insane type of runners. So these are multi-stage runners that are doing like multi-day journeys through like pretty harsh environments. Sorry, I've lost my notes here. This is going to be probably the less organized of it because I don't have a nice PowerPoint. I'm trying to read my own handwriting while doing this at the same time. So we're dealing with endurance runners. Again, these people are going to be extreme runners, ultra marathon foot races. So they've run through different desert areas, Gobi Desert, Atacama Desert, Jordan and Madagascar deserts as well. This is published in the journal, Clinical Journal of Sports Medicine, impact factor of 2.28 from 2022. So a pretty decent journal. I've read a few articles out of it. They tend to have pretty strict peer review guidelines. I'm happy with the quality of the journals that are published here. Or quality of the articles that are published through this journal. And this is a prospective study, and what they're trying to do is trying to figure out whether or not paper tape really does work well as a preventative measure for blister prevention. The authors did a previous study, but they weren't satisfied with that methodology, and they felt that there was much more to delve into. So that was the impetus behind this study here, was to get drilled down and look at paper tape in a little bit more detail and try to get in a little bit more of a controlled study at this point. So that's kind of what brought up the idea for the study. There is a conflict of interest with one of the authors, with actually Grant Lippman. He does have a book, The Wilderness First Aid Handbook, that he reports that he does talk about and promote this type of taping technique for preventing blisters. But none of the other authors did have any conflicts of interest that they reported with the study. So these authors looked at multi-stage marathon runners through several different multi-stage events, looking at to see whether or not paper tape actually does, pre-treatment with paper tape actually does prevent blister formation. And the alternative was no paper tape use at all. So it was either they had the paper tape on or they didn't have anything else. It was just a bare foot. And then the nature of the outcome was whether or not they had a blister develop on the foot that had the paper tape on it, in particular, whether or not a blister developed in the area that was actually covered with the paper tape. So the authors started out to try, this is titled as a randomized prevention trial. This was prospective in nature. They did plan ahead. They did set up the study design. It was not retrospective or ad hoc. There was some pre-planning involved in this, and as well as like IRB approval and things of that nature. But it wasn't necessarily randomized. They did try to randomize it in the beginning, but that was very loose. And then through subsequent stages, there really wasn't very much control throughout the rest of it to keep it randomized or blinded and things of that nature. We'll get into that more in some of the other topics here. As far as the study population, again, we looked at ultramarathon runners. Again, randomization. So they tried to do it, but it didn't necessarily work, mainly because they flipped a coin. They tried to come up with one foot or the other, but then they also gave the runner the option as far as like on that foot where to have the tape. But if there wasn't any blister areas that the runner typically came up with, then they just randomly put a piece of tape on, but it wasn't for every single runner that they randomly taped one spot on the study foot. That was kind of haphazard. And then after that, after subsequent stages, they gave the athlete the option to either tape their own feet or to have the medical personnel tape their feet for them. So there wasn't really any control through these multi-day stages as far as the same location being taped and being taped in a consistent manner. There was a little bit of, and because of that also there was bias injected into it, predominantly because they were, for part of some of the tapings, they were relying on historical knowledge of the runner itself. So they kind of knew where they developed blisters. So we're not really, in effect, that's more of a pre-treatment for known blisters in my mind, rather than actually trying to prevent new blisters from forming. Inclusion, exclusion criteria, they limited this to people that did not actively have any hotspots or blisters on their feet. If they had either a blister or hotspot, then they weren't included. And they also limited this to English understanding participants as well. So in that effect, it could have opened up their pool and give them a little bit more diversity. If they hadn't had that limit on, they don't really go into how much they feel that criteria limited their pool. But it does appear, though, that they were able to get enough, even with those limitations, they were able to get enough participants to have sufficient power to the study. This is a pragmatic methodology. Is it flawed? I think that they did the best that they could given the circumstances. I think they could have been a little bit more stringent as far as like consistent taping throughout. And also with the post study survey and things like that wasn't very tightly controlled as well. So I think there could have been a little bit more controls with this. They did register through their own IRB, and they also did have another external IRB that they gained approval for this study with. As far as the results go, they do report statistically significant results of reducing the number of blisters on feet that did have this pre-tape treatment completed versus feet that were not taped, or for patients that did not comply with the regimen. The strengths and weaknesses of the article, kind of already talked about it already. In the other things, I think that they could have been a little bit more stringent with carrying through the multi stages. They did talk about some of the different conditions and external factors that may have led to kind of, I know with the Gobi Desert, and there was another one, there was a very higher incidence, much more higher incidence of blisters compared to the other two races. They point out that, this was a much wetter course and things like that. So the tape probably didn't stick on as well, which could also, factor into whether or not this is a really good method to use or not, especially if the tape is still falling off. You're still really open to developing blisters more frequently and stuff like that. So they try to spin that into a positive of, a blister forms underneath of the tape. You can take the tape off easier without it disrupting the blister. maybe, but if it isn't there to begin with to prevent the blister, then what good is the method even doing? At least in my mind. And those were pretty much the key findings. One interesting thing that they didn't mention is with the taping is that they didn't necessarily get a lot of blisters underneath of the tape areas, but they saw more blisters around the areas that were taped. So like along the edges of tape. And I wish they would have explored that a little bit more, because they would have gone into technique, who, at what stage were these developed or noticed, and who applied the tape. Was it the medical expert, or was it the participant themselves? So that can also be an influencing factor, because if there are like wrinkles or something like that in the tape, it was done by the participant, then that would also, increase the likelihood of blister formation. As far as clinical contacts, I think it's another tool bag to have. I'm a big fan of moleskin personally, so that's what I have in my med pack. But if I run out of moleskin or I don't have it with me, I think this would be an applicable method. So that's really all I have at this point. I'll go ahead. I'll open it up to the floor for discussion here.
All right, great job. It's a good skill, and essentially the reason I started this journal club series is not only to teach and learn about cool wellness medicine stuff, which is the fun part, but if you haven't presented journal club style presentations before, or you haven't truly digested to know if an article is high quality, if there are biases, if it should actually change your practice, that's essentially the main reason this was started. So this was a good showing of how to know if a study is appropriately addressing its hypothesis, if it is of bias, if it has funding that is questionable. So this was a good way to sort of see the detailed like a presentation style for a true journal club. So has anybody actually used paper tape for their own blisters or when treating patients or friends, family? I'm going to assume that's nil. So in my first aid kit, whether it's for my day hike or bike pack, my group, oh, sorry, my dog's trying to get me. If I have my kit that I use for my group, or just like for myself, if I'm going on my own trip, I keep paper tape, and it's actual paper tape. It's like if you've been in a hospital, you've been in a clinic, it's not silk tape, it's not foam tape. It's just like, and it's not electrical tape, paper tape. That's typically what you use on like wound dressings. So that is the key. And when I've taped people or myself, like I really am careful about not getting any folds or creases. It feels really weird the first time you do it as a preventative. I've had decent luck with it. Feels weirder if you already have a blister or a ruptured unroofed blister. Leukotape. Hey Joe, can you share a link or a picture of what leukotape is? So I had pretty good luck with paper tape. I think the next article is going to get into some of the other methods, so I don't want to steal any other methods right now. We'll get back to that later, but this is kind of what people use when they're at a race. They use a couple other methods, but paper tape is a pretty consistent one. Has anybody had their trip cut short or heard of somebody's trip just getting miserably, frustratingly ruined by blisters?
Oh yeah, absolutely.
Yeah. So I don't know, 2-3 winters ago, I was Nordic skiing with a group of friends in West Virginia, and I was just renting boots because I hadn't bought my own setup yet. And even though they're very worn in boots, they weren't properly fitted. I had really good socks, but there was still loose space around my shoe. within my shoe. I got pretty bad blisters on each heel. That wasn't so much fun, but because we were doing like 14 to 23 miles a day. And then I didn't have paper tape. I had an extra pair of socks. So we can talk about that method later. But if you have loosely fitting shoes, there are other ways to like fill the void. But paper tape is a pretty consistently taught one in wilderness medicine. I think it was the 2019 winter or the 2019 summer WMS conference that Grant Littman and his team at Stanford presented the article that was just presented here. And it was kind of interesting. I was a fourth year resident, I think. And it was interesting to me as such an, I don't want to say early learner, I've been through college and med school and now residency, but so many people in the crowd had never heard of it before or had never used it before. So I wouldn't say it's new, but it is still not really that talked about. So that's why I chose it for this, or my fellows chose it for this month. Any other questions about paper tape or this article?
I've used climbing tape instead of paper tape. Found that I have really good luck with it. Sometimes doing a little piece, if there's already a blister, doing a piece backwards in the middle of the paper or the tape, so it doesn't stick to the blister. But I find that it sticks a lot. Like I've always had, every time I use moleskin, I feel like it ends up falling off and causing a worse. So. Oh yeah.
So, hey Joe, I'm looking at the link you sent about the leukotape. I'm just curious about the texture myself. It looks to me like it would be essentially the sticky part of a regular Band-Aid. Is that about what it feels like? Oh, is he still there? Yeah, he's here. Hey, Joe? That's okay. I haven't personally used climbing tape for. He texted. He must not be able to.
Yeah, leukotape is relatively similar to like climbing. I know climbers use it.
Yeah. Okay, cool. Well, that's another reason is I learned a lot myself because never heard of leukotape. To mix things up a bit, because there is another article on blisters, which is quite important. And we debated whether to include like, frostbite and trench foot in this talk. I think we're going to get back to that at a later date, but keep in mind about foot care, including a lot of other methods than just blister care. We can talk about that briefly at the end. Who is presenting the ankle fracture lecture or presentation?
That's going to be me. Can you hear me?
Yeah, I can. If you are ready, let's switch gears a little bit and do fracture care.
Yeah, let's go for it. So let me know if my audio goes out at any time and everyone. I'm in a place where they're playing excellent music, but it's kind of loud. So just let me know. I'm new to the scene here. By the way, my name is Andrew Zwijak. I'm a third-year medical student at Rosalind Franklin University, Chicago School of Medicine. Very much interested in emergency medicine, particularly wilderness medicine. For undergrad, I went to college in Helena, Montana, and I was a EMT at a rural EMS agency out there for about 2.5 years. And so saw some interesting things and some beautiful forests and mountain ranges. And so definitely would like to perhaps get back out there in the future, but we'll see. And so this is my first time doing this. And so I didn't prepare a presentation. Otherwise I would have. I'm going to share my screen just to share the article because there's 2 really great images in there. So bear with me one moment. All right. Someone just shout out if you can't see the article. Otherwise, I'm going to assume you can. So anyway, this is my article. So the title of the article was Field Management of Displaced Ankle Fractures, Techniques for Successful Reduction. So the article covered quite a few things for its short stature. However, it focused on 2 main things. And 2 main aspects of the reduction process as it relates to doing so in more austere environments, the hematoma block for analgesia, and then using what's called the Quigley method for the actual reduction of the ankle status post dislocation or fracture itself. And so we'll go into a little bit of background first. So this article was written by Dr. Daniel Brian Dean, the board certified orthopedic surgeon specializing in new surgical techniques to aid in pain relief and restore function. So he's very qualified to discuss this topic. And as you can see, the journal is in the Wilderness and the Environmental Medicine Journal, who has a goal of disseminating comprehensive wilderness medicine knowledge. So again, pretty appropriate. And it appears to simply highlight a lesser known but potentially helpful technique to reduce an ankle dislocation in a wilderness setting, where things like IV sedation, extra hands, and then real-time monitoring of vitals and rhythms for sedation that would normally be done in an ER is quite difficult. So that's basically what this article was about. It's not an RCT or anything. There's no conflicts of interest that I know of. Whoops, sorry, my notes went away. Okay, so basically this article is focusing mainly, well, on anybody who has an ankle fracture or dislocation. However, mention that persons older than 55 years of age and who have signs and symptoms that suggest some form of neurovascular compromise after fracture or dislocation are epidemiologically the greater proportion of patients who have this issue and who these methods could be applied for. And so the interventions, I'm going to briefly mention that are discussed. Sorry, that's X. Okay. Are applicable to the expedition setting. And we're focusing namely on the analgesia, and then as well as the reduction method. The first one, the analgesia method, is known as the hematoma block. I'm going to briefly cover it because they do a great job here and they show a great image of how to do so. So it's an effective technique. It requires injection of 1% lidocaine without epi into the fracture hematoma. And it can actually effectively numb the entire region around the fracture. The author of this paper stated that in 2 studies, I believe, demonstrated that in terms of patient satisfaction and ease of reduction, doing the ankle hematoma block is comparable to conscious sedation, which would normally be done in an ER. Because if a patient has an ankle fracture or a dislocation, ideally in an ER setting, there'd be some IV sedation going on, which would allow for full manipulation of the ankle to get it back in place. However, in the wilderness setting, as I said prior, without IV sedation and the ability to monitor vitals and other physiologic parameters regularly, it's kind of difficult to do so. And so having something that has demonstrated to provide almost equivalent patient satisfaction in the past is very helpful. So this is how it works. So infiltration of 1% lidocaine into the ankle is accomplished by injection using a 20 to 22 gauge needle through an anteromedial approach. And so there's palpable landmarks that can be used to define where you're going to inject. This consists of the tibialis anterior tendon and the medial malleolus. So tibialis anterior, medial malleolus, of course. So although the anatomy can be distorted in a severely displaced fracture, the landmarks are usually still identifiable. So after the skin's sterilized, you insert the needle approximately midway between the 2 landmarks in a slightly lateral cephalad direction. As it's advanced, it's common to impact the talar dome, and just a simple repositioning of the needle into a more cephalad angle allows penetration of the joint in the fracture hematoma. Once you aspirate some dark blood, which confirms the needle position, inject 10 to 15 mils of lidocaine, easily flow into the ankle with little resistance. And about 5 to 10 minutes later, you'll have adequate analgesia. So it has a pretty cool photo I wanted to share that depicts where that's going to take place at. And with this, you should be able to manipulate the ankle quite easily to be able to try and get it back into proper position. What I'm going to discuss next is the second thing the article focused on. It mentioned a little bit about proper splinting. But the second thing that the article wanted to highlight and focus on, which was the purpose of the article, was the Quigley maneuver, which is basically, as they describe, a method after several attempts at manipulating the ankle back into position fails. It's a Quigley method that can be used. It's actually used in the ER as well. Using like an IV pull. This is an image of it. And so what will happen is the stocking can actually be wrapped around the foot and the lower extremity, and it can be tied to an IV pole or a tree apparently. And you can use a lot of things for this. It's actually quite helpful for more wilderness setting. And so I'm going to read through again just this one part because it goes along really well with the image, and then we'll break down the article just a tad bit more. And that's all I got for you guys. So basically the injured lower extremity is suspended and it's cased in a tubular fabric sheath, extending the length of the leg out beyond the toes. The weight of the leg stretching the fabric is actually what creates the force. It's like an axial and an internal or external rotary force, depending on the dislocation. As the extremity hangs for about 20 to 40 minutes. That's will result in gradual reduction of the fracture. The author here states that he's found this method to be very successful in achieving anatomic reduction in ankle fractures and dislocations that he's seen that weren't able to be directly manipulated back into position. And it's presumably due to those forces allowing the dislocation to reduce itself. And like they said in the hospital setting, usually it's a tubular stockinette that's used for about the thigh secured with tape for this. 2 to 3 feet of excess stockinette extends behind the toes, and that's what's tied to that IV pole that I mentioned about leg hangs, now plantar flex position. It could be easily improvised in the field with the use of any relatively tight-fitting pants or even long socks. And then after their successful reduction, ankle should be stabilized as previously discussed. And the Quigley's traction also facilitates splitting of the injured ankle with minimal assistance because the split material can be applied while the extremity is hanging in traction, as I said. Just a few more points, then I'm going to wrap this up. So we kind of covered the interventions that were discussed in this paper. As far as a control, obviously there's no control population directly against the people who are receiving both of these methods for ethical reasons, as well as this paper to review, of course. However, it did speak about using these methods in the context of other in-hospital methods used to do the exact same thing. As I mentioned with the analgesia, it's comparable using the hematoma block. And then likewise, the Quigley method is actually used in hospitals as well. So it's similar to also, the article highlighted that it's similar to also go to the Quigley method in hospitals if you have complicated infections as well. If I'm speaking out of context, just a third year, let me know. So as far as the outcome of the study, again, yeah, what I already basically covered, just highlighting the uses of these, the fact that they are comparable to other things that are restricted to only in hospital use. And so one note of potential bias, I'm sure you can guess it, is when the author himself did mention that he uses this and it's really helpful in his practice, his clinic. There was, they mentioned 2 studies that supported the that using a hematoma block was comparable to IV sedation for reduction of ankle fractures and dislocations in hospital settings. They provided the references and studies and they check out. However, there wasn't really more articles on the Quigley method. And there are other articles that are out there referencing this method as well for both in-hospital and out-of-hospital use. And so it would have been nice if the author referenced some of those. Now that I mention it, I didn't exactly check the dates of those articles, so potentially this came out before them, but this method's been around for quite a while. And so it would have been nice if, I'm sure there were articles out before about this that perhaps he could have referenced. Not sure if they highlight, epidemiologically, whether or not this is comparable in hospital and in pre-hospital settings. However, it would have been nice to have just a little bit more literature support there. Otherwise, I believe that's about all I have here. So just to wrap up, the key findings of this is that the use of the hematoma block and the Quigley maneuver are potentially beneficial things to consider in the wilderness setting with a patient who has a fracture or a dislocation and is greater than 2 hours away from definitive care, and especially who has symptoms of neurovascular compromise as well. The author's references do support his conclusions. Overview of techniques used to perform said maneuvers helps to share this vital information. But further research, like I said, is indicated to continue supporting use of these methods, especially for the Quigley. And just a FYI, MRAP highlights the Quigley maneuver during, it's like the January 2017 episode, which is on ankle fractures. Just look it up in the search context. And I have no clinical context because I'm just a third year med student. Appreciate any feedback you guys have, but thanks for giving me this opportunity. I really enjoyed it.
All right, great job. And I chose this one to hopefully highlight, and that you got to it very keenly at the end was indications of when to actually do a reduction in the austere setting. Hopefully an appropriate background of orthopedics, whether it's orthopedic surgery residency or ER residency or family medicine with a key focus on orthopedics. But often in wilderness medicine teaching, you're trained, especially if you're doing like the wilderness first aid course or what do they call it? The wilderness life support for the medical provider, is taught not to reduce unless it's causing like such undue pain that the patient can't be like reasoned with or extricated otherwise, or if they have neurovascular compromise. Those are the two keys essentially, and time. So let's say you have like an open comminuted fracture and there's loss of pulses. Yeah, that needs to be reduced. And the open comminuted part was just to make it dramatic, but it's neurovascular compromise is what actually makes it concerning. Or if that could potentially change whether a patient can assist in their own extrication, or if they're going to be a full litter carry, because a full litter carry is, you need a whole team. It's going to take hours. Patient can walk, or you can assist them like with a splint and like hobbling down the trail. Like that makes a big difference. So that's why you'd want to do this. Now, has anybody used Quigley method or done a hematoma block?
So I have. I can provide my name's Sally. I'm an orthopedic surgery resident. So I can provide a lot of clinical context on this. Hematoma block is actually our department's preferred analgesia for all of our ankle fractures, whether they just be fractures or fracture dislocations. And I can actually probably count on one hand in 3 years the number of ankles that I've had to sedate in order to get an adequate reduction in the adult population. So it works incredibly well. Quigley's maneuver is something that I use if I'm unable, basically if I don't have any help, if I'm completely by myself and there's an ankle dislocation and I've failed kind of my first maneuver, because a lot of times with just a one person assist, you can get an ankle reduced with someone basically essentially holding the patient's on their back with their leg flexed at the hip and flexed at the knee. So kind of their leg making a 90-degree angle. Someone providing counter traction on the thigh with the knee bent, and then me kind of standing at the foot, pulling axial traction, and then trying to fix the sagittal plane deformity, basically trying to bring the dislocated talus back underneath the tibia. Usually that with a hematoma block is more than enough. But Quigley is a great option when you're by yourself and you need to get these patients' muscles to relax, or if you find a really unstable fracture, it can help to hold things reduced while you split them. I never thought about using it tied to a tree. That's actually a really ingenious method. I also will say that I work with a wilderness EMS group out of Baltimore, Maryland. That's where we're actually Baltimore, Frederick area. And we serve Maryland, DC, and Northern Virginia. And we actually had a patient back in December who had a trimalleolar fracture dislocation at an orienteering event. And we were unable to do a hematoma block due to the environmental situation. So it was a very rainy, muddy day, and we were on the side of a hill. So just keep that in mind, that that's something that's going to limit your ability to do this in the austere environment. We actually used intranasal fentanyl. It's something that our team carries, and I know there's a really good article from the WEM journal a few years ago talking about ski patrol carrying intranasal fentanyl as kind of their method of pain control in the mountain and how well it works. So we were able to use that, reduce the ankle, and this patient was actually able to help us perform an assisted walkout. Otherwise, extricating him would have been a really difficult situation. I think we would have been dealing with some additional issues of hypothermia because it was about 35 degrees and raining when this happened. So some clinical context for the article.
Yeah, it can definitely make or break your extrication method of choice. This Quigley is somewhat similar in theory of approach to when we hang patients like wrist fractures from traction, those what looks like little finger traps. And then you can reapply the padding while they're already hung up, and the hanging them can make it easier to do a hematoma block to the wrist as well. It makes anatomy easier. And I think what a lot of learners, and especially patients, you'll find your practice can be quite variable based on the patient you're treating. And I don't mean anatomically, let's say mentally. So if a patient is like quite agitated or histrionic, truly has a low pain threshold, I found that the hematoma block, just the sheer idea of me coming near a patient with a needle, has freaked out quite a few patients. If you can describe what you're doing well, if you can explain to them you've done this, quite a few times, great success, they might be amenable to it. But a lot of stuff in medicine you change if patients can't handle like minor inconveniences or typical go-to things. So I just recently had an ankle trimalleolar fracture. I work both at a 750 bed tertiary care center and a little 12 bed critical access hospital. So they're very different. And I was at the little shop where I don't have anesthesia, I don't have orthopedics, I don't have any backup. However, I was lucky in that I had a PA student and a PA and a respiratory therapist that day. So, but this is a patient I'm talking about where I mentioned the hematoma block, how often I get good success with it, and they were just not having it. So I had to do an actual sedation. And if I didn't have assistance, I might have done this Quigley method, because if you're doing a sedation and a procedure to reduce the fracture, your mind's getting pulled two different ways. And at the end of the day, patients or your pulmonary status takes precedence over reducing a fracture. So I had to focus primarily on the sedation. And then I had RT helping if I had to maneuver airway. I had two PAs essentially to help reduce and apply the splint. So this, if I didn't have all the help, the Quigley would have been fantastic. I still might not have been that keen on sedating somebody if I didn't have backup though, because I just would have had to like put the leg down and focus on airway if something went bad. But yeah, hematoma blocks are fantastic. I use them quite a bit in residency and now as an attending. I've never done it in the austere setting, and I don't really know many who have, but it is a fantastic skill that if it's not a rainy, muddy, gross situation like Sally mentioned, would probably get you a long way. Again, if you can just splint in position of comfort, if it's upper extremity or if it's lower extremity and there's no neurovascular compromise, the splint is almost better for pain control, just stopping movement, than anything else. If you can just splint in position of comfort or position of function, we all have the different phrases for our anatomic comfort, but that might be enough to get them out. But if they're neurovascularly compromised, you would want to do this. Anything else to say about that, Sally, since you're the actual ortho person here?
No, I think that was pretty accurate. And just for our colleagues who maybe aren't comfortable reducing fractures, if you encounter a patient with neurovascular compromise, I'm talking decreased pulses, a little bit of numbness and tingling is not anything we're ever worried about, but decreased pulses, cool extremity, there are very few things that traction will not fix. Do not be afraid to pull on it a little bit, just grossly try to make it look like the patient's contralateral extremity and splint it where it is. Most of the time you will get the pulses back and the patient will be so much more comfortable. And there's almost no situations where you're going to make something worse than it already is. You're already dealing with a limb-threatening injury. That is a very easy thing that you can do if something that you're feeling comfortable with. Just try to make it look straight. You could very well save that person's arm or leg.
Yeah, I think that it was early in my residency that I saw my first open trimal fracture dislocation, and like I could see open medial malleolus, I could see the medial joint space, I could see the talus. It was, luckily the patient was not conscious and aware of what was going on. But that was my first exposure to seeing how to actually do this. And exactly what she said, you'll put traction, you'll try to make it look like the other side. But oddly enough, and this makes you a little nervous at first, you want to like hyper exaggerate the injury position it's already in, and then because you need to get over the lip of whatever joint line it's affected, whichever limb. So you're essentially going to exaggerate the injury, pull traction, and then while maintaining traction, realign it in hopefully a good anatomic alignment. And there is nothing more satisfaction than getting your post-reduction film and showing, and then the radiologist reads near or anatomic alignment. You're just about the most satisfying thing you can have.
Yeah, absolutely. And even orthopedic residents, even in a tertiary care hospital, will occasionally reduce things blind when it's necessary. So this is not just limited to the wilderness setting. Like I reduced a open femur fracture with decreased pulses 2 days ago in the trauma bay without having any idea what it looked like underneath. So don't worry, we all do it.
Yeah, if it's life or limb threatening, if it's neurovascular compromise, you're not gonna, hey, where's X-ray? Why aren't they here yet? You just pull on it. And I've had to do it when patient doesn't have an IV and hasn't had pain meds, because my attending was a little overzealous about time to loss of limb. I think an extra 30 seconds for some meds would have been okay. But any questions about reducing specifically ankles, because we're talking about feet? Any questions about toes? I think fingers and toes are typically pretty easy as far as fractures or dislocations go. Okay. Well, let's move on to our last article, and then we can talk about some other blister care. And I can tell some people, thankfully, are new to this program and somewhat new to the WMS, if not FALM program in general. So we could take a minute at the end to talk about that if you'd like. But let's cover our final article. Take it away.
All right, great. Thank you. Can you guys hear me?
Yes.
Okay, great. I'm going to share my screen here. Great. Yeah, so my name is Prajwal Karanali. I am an incoming PGY1 at SLU School of Medicine in the emergency medicine program there. I'm going to be presenting this article here. It's the Prevention of Friction Blisters in Outdoor Pursuits, a Systematic Review by Worthing, Percy, and Jocelyn. I kind of got interested in this article because, I'm a bit of a distance runner myself. And I remember at my last marathon is the first time I had a blister. And I can definitely tell you that I think it affected my time. It definitely wasn't comfortable having that, feeling that in your shoe at around like mile 25 or so. And I saw a really bad one that my uncle had. So, it was interesting to see that there's some research being done on how to prevent these from happening. So foot friction blisters are a highly relevant topic in wilderness emergency medicine because of how common they are. They affect a large percentage of military personnel, endurance athletes, and hikers. Like I know from experience, they're associated with poor race performance, and they're associated with the risk of developing additional musculoskeletal injuries because individuals will often alter their gait to offload the affected foot. What is a blister? A blister is an injury that occurs within the epidermis, specifically at the layer of the stratum spinosum. Initially presents with redness, followed by blanching, and then a pleat in the epidermis, and then filling over the next 2 hours. The techniques described in the paper that we're going to get into look at ways to reduce the friction forces by reducing mu, which is the coefficient of friction in this equation in the top right. They also look to reduce the shear force and in other ways to reduce the frequency of shear forces. So in this article, basically a group of physicians from the departments of physical medicine and rehabilitation and emergency medicine conducted a systematic search and qualitative analysis of prospective controlled trials to determine if socks, antiperspirants, or barrier strategies were effective in preventing friction blisters in the foot during wilderness and outdoor pursuits. This is the only systematic review of literature on friction blister treatment based on a Google Scholar and PubMed search that I did. The article aimed to define clinical practice, if possible, because there is currently no standard of care to how to prevent friction blisters at this time. So one of the interventions that has been tested is using different types of socks, specifically the use of textile fibers like padded polyester in the sock. And the idea with this is to try and help keep the foot dry by transporting moisture away from the skin through wicking. The wicked moisture is then distributed throughout the sock, and as a result, there's more surface area for that moisture to evaporate from. And the idea behind this is to ultimately reduce that coefficient of friction. Similarly, antiperspirants kind of work in the same way in terms of reducing coefficient of friction. The reason is it's known that moist skin has higher frictional forces compared to very dry or very wet skin, and therefore antiperspirants are thought to reduce the overall frictional forces by reducing the coefficient of friction. One example is aluminum zirconium tetrachlorohydroxyglycine. It's used in typical antiperspirants that people might use, like Gillette. And the third one that they get into is the use of tape, and specifically, like Alex mentioned in his article that he presented, specifically paper tape. And this also helps reduce a coefficient of friction. This is a nice video that shows, one technique of, taping a foot. I saw some other images online, but this might be interesting for people who might want to look into using this technique. So like I mentioned, this is a systematic review of existing literature. Basically, the researchers looked at 1,838 individuals that were quantitatively analyzed from all the articles that they picked out. These individuals were from the US, Europe, and China, various China militaries, or they were endurance athletes. The article reviewers were blinded to the study results. The papers that they analyzed presented a combination of objective and subjective outcomes. However, the authors of the papers only included articles with incidence data that was included in the study. They had a really detailed list of inclusion and exclusion criteria when they were coming up with their systematic review. I won't go into each one, but some of the ones I thought were pretty important were that they made sure that all of their studies that they analyzed were prospective controlled trials. And then they also made sure that at least one of the outcome measures that the paper described was incident data. And important exclusion criteria, in addition to obviously the articles not being case reports or case series, et cetera. They also made sure that the blisters weren't created by artificial means or secondary to a pathology like diabetes. And they also made sure that the blisters were on the foot when they were picking up the articles. A little bit about their methodology. They found a total of 806 articles from their PubMed and literature search. These ranged from the dates 1950 to 2016, and they found these articles using PubMed and Embase. Of these, they found that 20 of them were further assessed. They were further assessed for eligibility, while the remainder, 786, were excluded based on their title and abstract. Of the 20, 9 of them met certain exclusion criteria, such as the blister not being on the foot or reusing data sets. So those were excluded, and then the remaining 11 were further analyzed. And of those 11 that were used in that qualitative analysis, they again ran assessment of risk of bias and confidence in effect using the Cochrane Handbook for Review of Systematic Interventions and the SIGN methodology. So using these two methodologies, they ended up excluding another 4 studies due to low bias control. And only studies of high or acceptable bias control were fully assessed, which were left with 7 of them. A little bit about the papers themselves. 5 of the clinical trials studied socks, specifically. 3 of them studied antiperspirant formulas and 3 studied barriers. And then 2 of the SOC studies and 2 of the barrier studies, the risk ratios that were calculated from those studies met statistical significance. None of the antiperspirant studies that they looked at, and none of those risk ratios met statistical significance. They utilized PICO method to analyze each article. For the 5 SOC system studies, they found that 3 of them met statistical significance for a decreased blister incidence following interventions. I highlighted those 3 articles right here. They ended up excluding 2 of these because they had poor bias control. And then for the antiperspirant articles, they found that 2 of the studies met statistical significance. However, 1 was excluded due to poor bias control. The other one that wasn't excluded, it didn't show any difference in blister incidence. Of the barrier studies, 2 studies met statistical significance. I've highlighted them here. None of them were excluded. And then this shows, based on the results of their ruling out studies based on amount of bias using those the sign criteria and the Cochrane methodology, they found that of the remaining studies, only the pre-tape 2 study, the one that Alex talked about, showed moderate confidence in effect estimate. The remaining articles that showed good statistical significance, those were deemed to be very low or low in confidence in effect estimate. So they basically concluded that the calculated risk ratio for paper tape versus no treatment was close to the true effect. And they stated that there was low confidence in the SOC and antiperspirant strategies in their effectiveness at preventing blisters on the feet. So ultimately, their conclusion was that there wasn't sufficient evidence to formulate a clinical practice guideline. So one of the strengths of this review was the meticulous methodology. They had very stringent inclusion and exclusion criteria. It was also impressive that the lengths they went to ensure that there wasn't bias in the articles that they were going to be analyzing using the SIGN methodology in the Cochrane handbook. One weakness was that they didn't register the study design before implementation. And also diversity in the studies prevented quantitative analysis. So even though they used the PICO method, the studies that they used had different types of there's variation in the interventions that they used and variations in the populations that prevented them from doing the complete quantitative analysis. So they settled for a qualitative analysis. A few questions to, if people are interested in discussing. Would any of you make recommendations for people that get blisters based on this study, and which method would you suggest for them? I'm also wondering, they basically decided that there wasn't enough evidence to come up with a clinical practice guideline, but they did show that paper tape is one option that did have some good evidence, but I guess they needed some more. So I was wondering maybe they could have expanded their inclusion criteria to include some retrospective or case cohort studies. I was wondering what some thoughts were on that. And then finally, what additional studies would you guys like to see before clinical practice guidelines could be created for blister prevention? Yeah.
All right, great job. That one was a bit more comprehensive since it covered multiple different methods and reviewed multiple different studies, which is that type of article is a bit more dense of a read sometimes. Any questions about that article? All right, so now that's 2 articles talking about blisters. Besides paper tape, what other methods have people used for blister care or blister prevention?
I'll start. So when I was a kid, I played soccer, ran track, and just was a crazy little kid. And I got blisters quite a bit in like middle school, high school time. But myself and my parents didn't really know how moleskin worked. So we would just cut out a little chunk of moleskin and put it on my blister. We would just cover the blister itself. We didn't know that you had to cut out a little donut. So can anybody say how to actually apply moleskin? Well, basically you measure approximately, you're not going to sit there with a ruler, but you want to have like a donut center piece of the moleskin removed, and that surrounds the blistered area. And that way those like surrounding moleskin raises up the sock or the shoe and prevents contact with that blistered space, or at least that's the theory. And I agree with whoever mentioned it earlier, but I've had moleskin just kind of fall off a lot. One method I found, and I don't have a study on it. I don't like to base care based on anecdotal evidence, but my favorite method recently for blister prevention, I used this for cross country this winter, skiing, as well as glacier mountaineering in Canada last summer. And I would just buy wool, specifically, very thin, and I wish they would sponsor me, but they don't. But Smart Wool is my favorite brand of socks of all time. And I would buy like there's ultra light hiking socks, like a very thin inner sock layer. And then I'll wear my typical hiking sock or mountaineering sock overlying that. And the theory behind that is that instead of shear forces against your foot, like was mentioned just a second ago at the beginning of the article with that math equation, it instead puts the shearing forces theoretically between the two socks. And I felt no blister formation at all, no hot spots even. So it sure worked for me. And I was in cold, long, kind of arduous hikes and cross-country skiing. So I've had great success with that. Paper tape's been great for me. Some people have tried duct tape, but I feel like it's too occlusive. And then you get some weird problems that happen from that. I think people just love duct tape. They just want to use it for everything. Has anybody used anything else? I know he mentioned essentially the components of deodorant, but has anybody used anything else?
So I've heard that Vaseline can be used, and I've tried that, but like I mentioned, it sounds like increasing moisture is actually not the best way to prevent blisters. And I didn't find that it helped.
Okay. One thing I'd like to mention again, I'm kind of hoping to figure out another session to more appropriately address this, but is anybody here, and I think if Douglas Sword has actually joined us here, he'd probably have experience in this, but has anybody actually seen a patient or taken care of a patient with pinch foot or frostbite? Whether it's toes or fingers, I guess. Okay.
This is Sally again with ortho. I've had some finger frostbite when taking hand call.
Was that in the hospital or more when you were in your EMS care?
This was actually this was in the hospital back when I was a med student in Ohio. We had anyone remember the polar vortex from a couple of years ago where the Midwest was like negative 20 degrees?
Yep. Oh yeah.
Yeah, then.
So this is something that I work in Southwest Virginia, and if you know much about it's kind of like the South, even though they don't like to be referred to as the South, part of the country that I live in. And the weird thing, not so much about primarily frostbite, but hypothermia, is there's more incidents in like warmer areas than there are colder. I think it's because Northerners are better at preventing hypothermia. But we get a shocking amount of hypothermia here. And I think there's an underdiagnosed occurrence of frostbite. So there was. Hey, Doug.
Hey,
Yeah, go ahead.
Oh, I'm just gonna say, I feel like I've seen a fair amount of frostbite, but usually it's already thawed, and most of it's in the ER as opposed to in the field. And the same with trench foot. I feel like most of it's seen in the emergency department. I think it happens. Obviously, it happens in the field, but I think by the time like we get to them, it's usually brought to the ER.
Yeah, I've definitely seen frost nip. I want to call it, which are sort of the milder or early stages of frostbite. But my main point is, oddly, this winter, again, I work in a big shop and then a little hospital. But at both hospitals combined, I had a total of 3 definite cases where I was the second provider taking care of a patient. First patient was a homeless man living in his car, and the temperature the night before had been sub-zero, and I'm talking Fahrenheit sub-zero. And the provider who saw this patient the night before diagnosed him with athlete's foot and just sent him home, which is his car and sub-zero temperatures. Gave him a couple recommendations on where to go, but the patient didn't have gas. So what are you trying to do with this poor guy? It's clear. And so I see the guy the next day. He can barely put pressure on his feet, and it's clearly not athlete's foot. His socks were wet. It was obvious that he had trench foot, actually. And because you can have cold and tropical, there's different subcategories as trench foot. And it's just odd. I think if you notice further in your career, especially if you stay along the awesome, fun track of wilderness or environmental medicine, a lot of austere care, pre-hospital care is just not experienced or taught in most med schools, ACP schools, residency fellowships, or whatever. So that was one case I had. The next one was a very similar case. It's another homeless patient where somebody diagnosed him with a separate hospital, separate doc diagnosed them with athlete's foot. I was like, how did just the setting, just the history alone should make you think that it's probably not athlete's foot. And I was I had my mind.
I've never diagnosed athlete's foot in the ER ever.
I couldn't believe it. And I was just like, it's not like I'm going to say, hey, my colleagues doesn't know what they're doing, because then they'll lose, you sound full of yourself and people lose faith in the medical field. But you just take context clues alone. And why in the world would this person have athlete's foot? And why would you assume this minor thing? So I would just hope somebody takes away from this that know what frostbite looks like, know what trench foot looks like. Just keep in mind that environmental disorders are pretty common. And I was just baffled. I came forward to one of the medical directors from my hospital system, and I think before this next winter, we want to come up with somewhat of a guideline for frostbite. We have one for hypothermia, but have some context for people to fall back on for frostbite. So it's what you're learning now can definitely come forward and help you later on, when you take care of patients and yourself.
Justin, this is Doug. I thought this winter was weird. We got super cold around the end of December, and then it was like spring ever since.
Yep.
And we only had like 2 or 3 frostbite cases that I was aware of, but we did have hypothermia cases. And I think hypothermia is easier because it's an objective vital sign. And I don't know that people pick up on the frostbite and the trench foot and such very easily, because you actually got to think about it.
Yeah. That actually brings up a good point. When I was a resident, I did residency just outside of Detroit. So it gets pretty cold in the winter. Not that much snow, but it gets pretty cold. And I had again, whether you're environmental, like athlete, endurance athlete in the winter, skier, most of these things are more common in like the elderly with no heating and the homeless people. So this was a homeless patient who came in as a night shift, I think. And he was just adamant I didn't turn the lights on. because they said he had a headache, and I was like, all right, I mean, that's fine. I don't know why you really don't want the lights on, but he's just complaining of hand pain. I was like, look, I need to see what I'm dealing with. I turned the lights on, and he clearly had first degree. Luckily, it wasn't beyond that at first degree frostbite. And then I had him, it's not like I was ready for frostbite. We just had him run his fingers under like warm water while I thought of something else, got my attending. And then later on, I checked on him again, and it had formed clear fluid-filled blisters, not blood hemorrhagic blisters. We've done topics on frostbite before, but just good physical exams and not acquiescing to patients' requests for not turning on lights. Like, you'll find things. Just do good physical. I've had students and residents who, and the ICU nurses would be laughing at this as well, but not doing a full skin exam on like really sick patients. Like, I found horrible sacrodecubitus ulcers and stuff, but just do a good exam takes you a long way in taking care of patients. But rather than just belabor that point, so I think in the link that you all followed was links to the website I made for the Journal Club website. Rather than me kind of go on and on about how to submit FOM credits, because I've usually done that quite a bit in the past, or what the schedule is and everything like that, just the website link has Google Drive calendar, schedules, Zoom links, recordings of all past sessions, articles contained in a Google Drive folder. Everything is in that website. So if you just kind of delve through that, it should be able to answer any question you have. And I'll see if I can just find the link real quick, but it's also in the email or the Basecamp post that I sent out. Does anybody not know how to access it though? I can send it real quick.
Could you put that in the chat?
Yeah,
I'm still going off of a link that WMS sent out in an email like 5 months ago.
Yes, working on it right now. Like I said, I'm still a little bit of a fog state because I haven't been sick for 3 years. I've been so careful with wearing a mask. Been so careful, but I finally got sick, and I'm like such a baby now.
You get the man flu, Justin.
It's bad. It's real bad.
Can I ask a question?
Yeah.
I've been listening to this thing. I've been debilitated from blisters in years past. I still don't feel clear on like what's the best treatment for a blister. Like I the moleskin thing doesn't. I don't know. It just doesn't seem right to me. I've cut the donut thing. I've piled up moleskin. It falls off. It still sort of sucks. So
Yeah.
What do you guys think? I mean, I get a hot spot. Maybe you can put this, paper tape or what was the other thing that was mentioned? The leukotape, right? I don't know if anyone's familiar with the Zentos product that's been recommended. But like, what do you guys think is the best treatment for either a hot spot or an actual blister that develops?
Well, I think we still have two of our presenters here who have luckily presented the blister articles. Alex and Prajwal, did you take any one treatment method away out of your presentations? I know they primarily focus on prevention, but from what you saw in your articles, what do you think?
Yeah, as far as prevention goes, I think paper tape is the best way to go. I actually didn't see too much about actually treating the blisters though, but I would have to say it seems like paper tape is the way to go because the article, had a low bias score based on the methodologies that they use to analyze that part.
So I've definitely liked paper tape. It's been kind of my go-to for that. Although I get a little sensitive with my feet, so I don't like things touching them that feel funny. It's just a little nitpick of mine. So I really like the double layered socks. Whether you can run with it too. Have an ultralight and a regular pair. I've not tried the toe socks, but one of the people in the fellowship I work with is a huge proponent of them. I just don't think I'd be able to handle gloves as socks. I think it would freak me out.
Yeah, they're like a pain to get on. Once they're on, I guess they're okay, but they're hard to get on. But again, what if you get a blister? Like, what is the from this group?
Actual treatment?
Yeah.
Yeah. So that is probably there is going to be an endurance race session in a couple months. We can talk more about like ultra marathon treatment, but it is a huge proportion of medical tent stops for ultra marathon, ultra cycling events is blister care. So it's definitely something to focus on. Treatment itself, anything you can do to reduce friction or wetness, so switching out socks is going to be huge. Again, that's just preventing worsening. It's not treating.
Right.
One of the main things I have found, whether it's ruptured or not, there is actually a big debate into whether or not to drain a fluid-filled blister, but that's not mostly what you'll see in the care of these patients. That's more of like a burn. But if you have a fluid-filled blister and it's truly causing like undue pain and annoyance, there is some debate to aspirate it with a needle, leave the roof over top for like a biologic Band-Aid, and then address it from there. Hemorrhagic, they sometimes think that is somewhat beneficial because it has some properties in the fluid of the blister that might actually help improve healing. So they're less a proponent of draining those ones, more so of fluid, clear fluid. But just an unroofed blister. Sorry, what?
Like frostbite.
Yeah. Yeah. Kind of the same.
That's not evidence-based. That's just sort of, medical.
It's just everybody thinking, hey, there's not much else we can do.
Yeah.
Similar to that. Actual blister, if it's roofed versus unroofed, I feel like it hurts so much more when it's unroofed because then you get that raw skin exposed. I have had paper tape put on those before, and it hurts because then eventually the paper tape has to come off. And the reason everybody says paper tape is it's very gentle. It's not very abrasive, which is why we use it in wound care too. So if you're going to use tape, I would use paper tape personally. I think I'd probably do paper tape and then double socks for myself and patients. A lot of the times they end up with so much tape on their toes or in the heels by the end of a race.
When it's for hot spots or for actual blisters?
More so for hot spots. Blisters. Yeah,
I would agree with that.
I would do my best to do the moleskin donut and then do my best to adhere the moleskin. Maybe paper tape around it or paper or some type of tape supporting moleskin because it's going to fall off. But you just want to try and protect any further friction against the blister itself. That's what I found is the best.
Yeah, that's
fair. Just not much. It's one of the yet another types of wilderness medicine where it's all about prevention. Because once it happens, you're kind of out of luck.
Sounds reasonable.
Any other experience with it? Because it's something that our fellowship has done a lot of race support, and that seems to be our go-to. And if there's other approaches, I'm happy to hear it.
Has anyone heard of a product called Second Skin? Second Skin. It's a little, it comes in usually it's like a little jar, but it's essentially a square gel pad that you can put directly on the blister, and then you have to secure it with some type of wrap. In my experience, I'm a big proponent of athletic tape. I just find that it sticks better on my skin and doesn't come off than other kinds of tape. You can secure it with athletic tape. You can secure it with like a Coban or really any type of sticky substance, but it allows whatever tape you put over an actual blister to kind of glide a little bit over to help reduce friction over that hot spot. And it has like a cooling effect almost, I think. And I honestly, I drain most of my own when I get them. I know you're not supposed to.
I'm looking at pictures right now. It does look, I might have to buy some just to try it out. It looks like they use it a lot in tattoo care because that's such a sensitive part of the skin at the time. Well, that'd be kind of fun to try out. we'll have to play around with different methods when we can.
It's really big in the athletic training world.
Okay.
Which is how I got introduced to it.
Hey, can I ask another question?
Yeah.
This is for Sally. Sally, this is Doug Swart. I'm in Maryland. You said you did a hematoma block and reduction somewhere around here. What was the context of that?
It was the JROTC region for PG County back in December.
All right, this is like AMP stuff, right?
Yes, it is.
All right, familiar. Got it. Thanks.
Yeah.
All right. Well, thanks for joining, everybody. Sorry again for me joining late. I was in a haze. It's kind of woke me up a bit. So thanks. Anyway, if anybody wants to join for future months, I promise I am more talkative usually and less troll sounding. So I'll see you later.
Hey, Justin, can you stay on for a sec for me?
Yeah, I'm going to turn off recording. So thanks, everybody. I'll see you next month. Next month's session is on animal attacks, terrestrial. Sorry, my dog's there's an attack right now. Terrestrial animal attacks.